Welcome. Welcome. Good morning, Chair Krupp, Vice Chair Choatson, Vice Chair Wallen, members of the committee. My name is Mike Reese. I'm the Director of the Oregon Department of Corrections. Joining me today is Assistant Director Jeremiah Stromberg, who leads our Community Corrections Division, and Kevin Bovenkamp, who leads our Healthcare Division. We also have online Dr. Robin Timmey, who's going to be helping us with our presentation. He is with Falcon, the consultancy group that we brought in to do a comprehensive review of our healthcare system at the Oregon Department of Corrections and to provide recommendations for providing better care to the adults in custody as we reform our healthcare system at the Oregon Department of Corrections. So as we move through this presentation, I want to start by giving you some context, an overview of the Oregon Department of Corrections, some of the challenges that we face in providing health care to adults in custody, the changing demographics of the adults in custody, talk about geriatric care. And when I talk about geriatric care, I'm referring to the health care that we provide to older adults. And in a correctional environment, an older adult can be somebody in their 50s because they often present about 15 years older than their chronological age. And that's because of a lot of unmet healthcare needs, a lot of substance use disorder and addiction challenges, and other things that lead them to have maybe, some accelerated aging processes. So you're looking at a picture of the Oregon State Penitentiary. It's one of our housing units. There's 40 cells on each level or tier, 2 adults to a cell. That housing unit is 5 stories high. It's single pane windows on the left side of the picture and cells on the other side. And it is an aging facility that houses many of our most vulnerable adults in custody. So we'll go to the next slide, please. And I just want to give an overview of DOC as we proceed, so you have some, again, context for our remarks. We'll be talking about our Health Services Division and the care that we provide to the adults in custody, some of the drivers of care, the costs associated with it, some of the challenges. We'll be talking about best practices in a correctional setting for dealing with an aging population. And then finally, some options that we're going to be presenting to you over the course of our conversations during the next year as we talk about providing better care to the adults in custody and doing it in a very cost-effective fashion. So let's go to the next slide. I want to just frame this under our mission. We are here to protect communities, promote accountability, and transform lives. At the Department of Corrections, as the director, I see that every day when I go into our institutions. We provide services to the adults in custody that does literally transform their lives, setting them up for success when they leave custody, holding ourselves accountable as well as the adults in custody, and protecting all Oregonians through the work we do. So DOC has 2 primary functions. First and foremost, we run prison operations throughout the state of Oregon. That's for adults in custody who have been sentenced to a year and a day or more in custody. We have 12 institutions with 12,110 adults in custody on April 1st of 2026 when we did the last population forecast. We have 11 male prisons and 1 female prison, and you can see the numbers of adults in custody. We also manage community corrections, and so we oversee the funding and systems of accountability for community corrections, where we have over 22,000 offenders on supervision. And we have 34 counties that manage those parole operations. And then DOC operates Lynn and Douglas counties. And next slide, please. This shows where we're located. As you can see, the footprint of DOC is across the state of Oregon. We have institutions in Tillamook. We have institutions in Ontario. Our largest institution actually is on the border with Idaho, our Snake River facility in Ontario. We have remote locations in Lake County, and then a lot of locations here in the Salem metro area. Our budget is a little over $2.686 billion. Most of that is general funds, and that primarily pays for the salary, the healthcare costs, and other associated costs of running our institutions. We do have bond funds that go towards the maintenance of the facilities, and then we have a very, very small number of federal funds that are used for some of the programs. We have over 4,700 FTEs. We are hiring, so if anybody's watching this presentation, you're looking for an opportunity to join us, we're hiring corrections officers, we're hiring nurses, we're hiring doctors, we're hiring food service folks, all of the different positions that make up the little cities that we operate across the state of Oregon. So our employees are our greatest asset. We have, as I said, over 4,700 of them. 70% of our staff work in our institutions providing security. They're there as doctors and nurses, counselors, work programs. We have people that do maintenance on the facilities as well as provide meal services. We have correctional officers in all of our housing units. So when you look at that level of tiers or cells in the Oregon State Penitentiary, on that level, there's a corrections officer that manages that housing unit where there may be anywhere from 50 to 100 adults in custody. Our staff are not armed. They use their good communication skills, their command presence to maintain order and security in those housing units. We have a lot of our staff that are focused on education and life skills. And I want to say we have a lot of great volunteers and vibrant relationships with higher ed, with work programs, with our labor partners, and it all is set up to really provide the adults in custody the resources they need to transition safely back into our community. So we'll pivot now and talk about the adults in custody. You saw that there's a little over 12,000 in 12 facilities. About 75% of them are there for person crimes. Those are the most serious crimes that you can be convicted of. It's the robberies, the assaults, the attempt murders and murders, things of that nature, sex crimes that really do impact all Oregonians. About 60% have issues with drug addiction or dependence. They have a diagnosed substance use disorder. And about 50% have severe to moderate mental health treatment needs. And I'll turn it over to Jeremiah Stromberg now.
Thank you, Director. Chair Kropp, members of the committee, for the record, Jeremiah Stromberg, Assistant Director of the Community Corrections Division with the Department of Corrections. The overview provided by Director Reese as to our structure and our budget and our mission has resulted in some extremely positive outcomes within our criminal justice system. And I want to share with you a few of the stats that in areas of outcome that we pay particular attention and focus to. In almost every category, Oregon rivals any other state across the nation in positive outcomes and the level of success that we see. With this first chart, I want to show you the level of employment and treatment participation for those who have left our facilities and are on community supervision. When you look at employment, we hover around that 58% of the population on supervision is employed. When you consider that less than 10% leave DOC with a job in hand, this is a significant increase of success. It shows that their time in custody, we spend a lot of time on skill building, education-based opportunities, workforce opportunities, so that individuals are prepared to rejoin the workforce upon release from custody. In addition, at any given time, about a third of our population is engaged in some level of treatment. Again, that time in custody prepared them that upon release to the community, they were ready to take advantage of treatment opportunities, programming in the community. That we had moved them beyond a place of criminal thinking and unwilling to take accountability, and it was actually worthwhile to engage them in treatment. And so another extremely positive outcome for us. About 72% of those that release from prison, that's the blue line, successfully complete the 3 years of post-prison supervision following their incarceration. This is one of the highest percentages in the country, and what this means is those individuals met the conditions placed upon them by the Board of Parole, and they were not revoked and finished out their supervision time in custody. That we see positive outcomes, that we see compliance, we see growth. The probation numbers as well, promising. We did see a dip, I think primarily during our pandemic years, but we continue to see a high level of successful completion of supervision. Not a direct correlation to recidivism overall, but obviously the more successful on supervision, the more likely for success then upon complete removal from the criminal justice system when there are no longer those safeguards and accountability processes in place. Recidivism is always one of those areas that we do continue to focus on. These next two stats, a little outdated, so I wanted to share with you the latest recidivism numbers from the Criminal Justice Commission. As of December 2025, 57% of everyone who released from DOC was not rearrested within the following 3 years. 65% were not reconvicted of a crime, and 88% were not reincarcerated. So in other words, there were arrests, there were some convictions, and the vast majority of those were convictions that did not carry a new prison sentence. So in a harm reduction model, we saw a lower level of crime. Area for us obviously to continue to improve, an area we want to continue to stay focused on, but we are pleased, especially when we look across the nation, where you see incarceration rates in some states as high as 75% within the 3 years following supervision. So we have seen some great movement, and we continue to see a downward trend overall in the number of arrests and the number of convictions for those on supervision.
Question, Chair.
Yes, please.
In the out processing of the adult in custody, do you speak to them about expungement, like after they fulfill their term in the prison and parole, etc., how they can get their records cleared, when, and the benefits of doing that?
Chair Krupp, Representative Tran, yes, we do. And we also rely on our community advocacy partners for support in that area as well, who are constantly working with both individuals in custody as well as released to the community to ensure that they know their rights and what's available to them. And even beyond the expungement piece, we talk to them about how they can get off of supervision early. And I was going to share some of those stats in a little bit, but as of today, we currently have 3,100 individuals that we have ended their supervision and let them off early, who otherwise we would be supervising today. And so we inform them what incentives are available, what happens if you show positive behavior, no new crimes. Not only can you get off supervision early, but makes you more likely to be eligible for expungement. The rest of our presentation today around health services, a big component of that is also DOC's authority to release individuals early to the community. And so I wanted to highlight for a minute here, DOC has the ability to allow some AICs to return to the community to finish serving their prison sentence. These are individuals in our custody who are not serving a mandatory minimum sentence. If they've shown positive behavior while in custody, they can receive up to 120 days early from off of their sentence back to the community. And we also ensure you must have a solid housing plan. We don't want to release anybody to the streets who otherwise would have a bed with us in one of our institutions. This program was enhanced with House Bill 3194. I think we put 3134 on the slides. So 13 years ago when we enhanced this program, more than 15,000 adults in custody have released early from their sentence. That equates to 1.2 million prison bed days saved If you do the math further, that is 3,300 years of prison time that has been avoided by this program, that individuals have served back in the community. The 97% success rate we put on here is that during that duration of time that they otherwise would have been in custody, 97% of the individuals did not violate by committing a new crime or being returned back to the Department of Corrections. This single-handedly is the most impactful program from 3194. It has had the most significant prison bed savings and cost savings of anything that incredible bill did for us at that point in time. But as you can see, it's only limited to less than 50% of the population within DOC. So our ability to release individuals early who are ready is limited and certainly has an impact then as we start to talk about our healthcare system.
Chair. Thank you. Thank you for the presentation so far. And that 97% success rate is remarkable. I think it's the highest percentage we've seen so far in terms of any success of any of the slides today. Would you support expanding either eligibility or scope or scale of this short-term transitional leave program?
Chair Krupp, Vice Chair Choatsen, I think what we've been able to see is that we can have a high success rate when we identify individuals who are exhibiting positive behavior in our institutions, have a solid release plan. And so given the success rate, I think there's room for growth, that we could continue to see public safety being recognized and successful, as well as reducing time in custody.
Thank you. One or two follow-ups, Chair?
Go ahead.
Is there any sense, and you can feel free to follow up, although Jeremiah, you may just know offhand, the cost per day when somebody is on community supervision under a program like this versus the cost when they're incarcerated, kind of what that average cost looks like?
Chair Krupp, Vice Chair Choatsen, the average cost per day of supervision is about $15.80 in the community. Our prison beds are much more expensive than that. So some individuals in our custody who have low health care costs, low other needs, might only be costing us, say, in the $30 range for incarceration. But others that you're going to hear about here shortly are costing us in the hundreds of dollars per day range in custody. So there is absolutely a savings and a significant difference between cost incarcerated and cost in the community.
Thank you. And then last follow-up question for now on this. The 97% success rate is the period in which they're out when they could have been in, essentially. Do we also keep recidivism data for folks who start their time out on the short-term transitional leave? I can imagine that they're getting kind of a softer landing with more support, and maybe that recidivism rate is lower in the long run as well, but I don't know if we have data on that.
Chair Krupp, Vice Chair Choatsen, the Criminal Justice Commission did 2 recidivism studies comparing the short-term trans leave population to the general release. Both these studies were completed pre-pandemic, so we haven't done one recently. In both cases, it showed that there was a significantly different lower recidivism rate for the short-term trans leave population compared to the general release. It sort of supported the hypothesis, if there's strong, good behavior in custody, we're more likely to see that continue as well back in the community. So yes, we've continued to see a lower recidivism rate for this population.
Thank you.
Question, sir?
Yes, please.
So the current eligibility criteria is no minimum mandatory sentence. So if we want to expand this, we have to consider some with minimum mandatory sentence. What are some of the group of folks that would pop into your mind that would be involved in the expansion if this was to be expanded? You get my question? Yeah.
Chair Krupp, Representative Tran, so the 2 primary mandatory minimum laws are Measure 11, which the director spoke to a little while ago. Those are our serious person-to-person offenses. And then we do have a portion of our population under Measure 57, which is our repeat drug and property offenders, who also are required to serve a mandatory minimum sentence. Those are shorter than the person-to-person offenses, but both of those categories prevent DOC, or DOC doesn't have the legal authority to release. So those are the 2 primary categories. The third, on a smaller scale, would be those that still fall under our true parole system and fall under the Board of Parole for determination of when they are eligible for release. So it would be within those three contexts that the legislature would have to consider a law change.
Thank you.
Thanks.
And turn it over to our Assistant Director of Health Services, Kevin Bovenkamp.
Thank you. Chair Kropp, Vice Chairs Wallen and Choatsen, members of the committee, good morning, and thank you for the opportunity to speak today. For the record, my name is Kevin Bovenkamp, and as Director Reese mentioned, I'm the Assistant Director for Health Services. That division is made up of almost 700 staff, about 700 staff, and we have a biennial budget of about $510 million, which is approaching close to 20% of the agency's overall budget. Next slide, please. And just so we're on the same page, we're going to talk just a little bit about some of the legal foundation for healthcare and care and corrections. Start this discussion off with some of these kind of foundational pieces. The Eighth Amendment of the U.S. Constitution, really the first case, the landmark case, was Estelle versus Gamble. That arose out of Texas, 1976 Supreme Court case that requires the government to provide constitutionally sound, adequate health care to incarcerated individuals. Oregon's Constitution follows that and kind of echoes that concept right along the way. And there, of course, are legal consequences when those things do not occur. When you don't provide adequate care, you get into some of those consequences, lawsuits, settlements, fines, and other court interventions. And I'm going to turn it over to Dr. Robin Timmy to talk a little more about some of the impacts of those things happening.
Morning, Chair Kropp, Vice Chairs Wallen and Choatsen, and members of the committee. For the record, my name is Dr. Robin Timmy. I'm a board-certified forensic psychologist and Vice President at Falcon Correctional and Community Services. Last year, our team conducted a comprehensive assessment of healthcare delivery across the Oregon Department of Corrections, including site visits to all 12 prisons, every medical infirmary, and every single point of care in the prison system. I'm joining you today from Helsinki, Finland, where I'm attending a conference and presenting on prison safety and violence prevention. And later this week, I'll also be visiting a correctional and forensic treatment facility here to learn from international practice. I would encourage you to view today's discussion through a national lens. Oregon's not alone. Across the country, correctional systems are grappling with aging populations, increasing medical and behavioral health needs, rising healthcare costs, and facilities that were just never designed to support modern healthcare delivery. Over the course of my career, I've worked in jurisdictions that have experienced major correctional healthcare litigation, states like California, Arizona, Maryland, Delaware, and numerous county jail systems across the country. And one thing those experiences have taught me is that these situations rarely emerge without warning. The problems are usually visible years in advance. And from my perspective, the most important issue is not litigation. Litigation is what happens when known problems go unaddressed for too long. The real issue is whether we are providing safe, humane, and clinically appropriate care to people who are entirely dependent upon the state for that care. The encouraging part of Oregon's situation is that the challenges are already well understood. DOC leadership understands them. The workforce certainly understands them. Healthcare staff certainly understand them. Many of the solutions are already known. The question before you is whether the state acts intentionally and proactively or waits until circumstances force the decision. And I think one of the most pressing issues, in my opinion, is replacing Oregon State Penitentiary is not simply a facilities project. It's a healthcare issue, a workforce issue, a public safety issue, and ultimately a question of whether the physical environment is capable of supporting the mission we're asking staff to carry out every day. I'll turn it back to Assistant Director Bovenkamp.
Thank you. And as Dr. Timmy mentioned, providing adequate care isn't really optional. However, providing care to the adults in custody is not as easy as it is to sort of match the standard of care in the community. And our population is a bit different. That some of those things that make it different, of course, are our incidence of substance abuse, about 12 times higher than in the general community population. Our incidence of hepatitis C is about 10 times higher. Many of these men and women have not accessed health care in the community for years. Things have gone unchecked and progressed to a point where serious care is now needed. There's a high prevalence of diabetes and hypertension. There's a high prevalence of mental health, about 50% or more are severe or moderate mental health needs. And then we've got an aging population, which just compounds a lot of the healthcare needs of the individuals. So that just kind of exasperates all of these things. Our offsite care is also more challenging than it can be for some of us in the community who try to access specialized care. So we'll talk a little bit more about that here pretty soon. From a budget perspective, you can see there's a pretty sharp increase in healthcare costs over time. We did go through the pandemic there. I wouldn't say that the need for healthcare was dampened, but probably the ability to access healthcare was reduced there for a little while. Coming out of that, you can see our costs continue to rise. Pharmaceutical costs, of course, are quite high. Medications typically do not go down. And with the amount of research into new medications and therapies available, those things continue to become available to the general population, and they tend to become more expensive over time. Go ahead, next slide, please. Yeah, back to Jeremiah.
So, Representative Tran, this goes back to your comments even around our mandatory minimums. What we're seeing is a significant growth in the individuals who are age 60 and older. As you can see here, our overall prison population has dropped since over the last 10 years, primarily during the pandemic years, and we haven't rebounded. However, the number of individuals in custody over the age of 60 has continued to increase. The vast majority of these individuals are serving a mandatory minimum sentence, which is why they are with us at an older age within our custody. And so with that growth, that leads to the statistics that Assistant Director Bovenkamp has provided to you, that we continue to see this increase in healthcare need and cost. We all know as the older we get, the more medical care we need, almost regardless of how healthy we are. So when you compound that with the stats that we just provided, it certainly creates a challenging opportunity for us. And since we don't have the authority to release these individuals to community-based healthcare treatment or assisted living, we have to continue to look at ways to improve our infrastructure within our facilities to provide for that adequate care.
So some of the impacts of us having aged individuals in our facilities. This is a picture of one of our infirmary beds. And as you can understand, our infirmaries weren't really designed to take care of the most serious healthcare needs like cancer treatment, hospice care. We've got individuals who have memory care issues, and so we're being forced to actually sort of assign extra staff to them to monitor and redirect them one-to-one pretty much all day long so that they're not getting into trouble or being harmed. Geriatric care, we've talked about, it continues to go up as our population ages. And we've got long-term stays. Our infirmary beds are quite full most days. It's pretty rare we've got a handful of open beds, and so we're always juggling who needs that bed the most. And we've got several facilities that I would say are in overflow status, like Snake over on the Ontario border by Ontario. Typically, there's a handful of men that are in overflow beds where they can't actually get into an infirmary bed, and we're just doing the best we can in some beds that are behind the infirmary. So our offsite care, just getting people offsite care has become one of the more challenging things in our system. And we have a medical appointment offsite care. It's something we can't deliver on site. We've got facilities that don't have a lot of space. It's hard to get some of the specialized clinicians into those facilities. So we end up taking trips into the community to access cancer treatment, orthopedics, surgeries, things like that aren't going to be done in the prison side. Just like most of us experiencing our own healthcare journeys or those of our families, these specialized appointments are typically not a one and done thing. If you have a surgery, you're generally going to have a follow-up appointment. If you've got orthopedic care, there's a series of appointments before you get to the point where they might be looking at surgery. There's MRIs. There's a lot of things that take people off site every day. And we're forced to prioritize and try to figure out who's our highest priority today. We're doing better with that, but we've got a demand that continues to increase. It's not leveling off. It's actually compounding and actually intensifying on us. So offsite care and access to specialty care is one of those things for a system we really need to pay attention to. And I'll turn it back over to Dr. Timmy for a few more comments.
Yeah, as I mentioned earlier, when we visited all the 12 prisons, we spent a lot of time with healthcare staff, custody administrators, and adults in custody throughout the system. And one of the things that stood out to us was the quality of the workforce you have in Oregon. Correctional healthcare professionals are deeply committed to their patients and to their mission. We heard consistent themes from staff across the state. They want to provide excellent care, and they understand the challenges, and they have a clear understanding of what needs to improve. They have a lot of great ideas that they shared with us. So we identified opportunities in several areas, including treatment space, healthcare data and analytics, policy structure, and the integration of medical and behavioral health needs into classification and housing decisions. And these are all important issues, and many of those improvements are already underway. One of our primary concerns, however, was the condition of Oregon State Penitentiary. Collectively, my team has visited hundreds of correctional facilities across the United States and internationally, and OSP stands out as one of the most antiquated and functionally obsolete facilities that we have ever encountered. The staff are doing remarkable work under difficult circumstances, but there is a clear mismatch between the population being served and the environment in which care is being delivered. At some point, no amount of ingenuity, dedication, or hard work can fully overcome the limitations of the physical plant there. And so when we discuss replacing Oregon State Penitentiary, we're not simply discussing a building, we're also discussing whether Oregon's correctional system has the infrastructure necessary to safely care for an increasingly complex and medically fragile population. Kevin?
Yeah, thank you. So back to the geriatric care, as you can see in this slide, although we cover about 98% of care on site, there is those trips that go off site. And in our geriatrics, the 2% is getting more expensive. So almost $70 million was spent in a 3-year period on off-site care, and those costs continue to go up. Almost 60% of those costs were for individuals that were 60 years of age or older. So even though that population is shrinking, the percentage of money being spent on it is increasing dramatically. This is just one example. If we could get to some different type of units on site, we might be able to stage people and provide a little different care to keep them out of infirmaries, keep them out of some of the extreme costly care. And so that's things that we'll be looking at over time and in some of those discussions with you.
Question? Thank you. The condition of care is not as optimal as it can be. Are there a lot of terminal patients who are opting for assisted suicide or, instead of staying in this environment?
Yeah, Chair Krupp, Rep. Tran. We do have a number of individuals that I would say it's not uncommon to have individuals at kind of hospice level of care on a daily basis. I think we just had a AIC pass away earlier this week, I think in just the last day or two. So I'm not aware that any of them are opting for assisted suicide. I don't know that's a service we could provide in a prison system. It's our duty to keep people alive, although we do allow the individuals to fill out long-term care orders so they can do a post with their physician. They can have a do not resuscitate order and those things, but I don't think we would actively assist somebody in committing suicide or ending their life.
Thank you.
Representative Chosen.
Thank you, Chair. Thank you all so much. I find this slide really remarkable, and I just want to make sure I'm kind of tracking it all. So it's pretty well documented that recidivism rates decrease as people age. And if you all have different data, for sure, please speak up. But assuming that's true, is this basically saying that we've got a small percentage of the prison population that is statistically, on average, the least likely to recidivate, driving a huge percentage of the healthcare costs and the costs overall, and that small percentage is pretty much increasing year by year as how big of a percentage of the entire prison population it is? Is that the right way to kind of look at it?
Chair Krupp, Vice Chair Chosen, that is correct.
So we can look around the country as well to see kind of what solutions are people coming up with. And it's really important that we think of these things as a combination or a continuum. Every state is a little bit different in terms of statutory authorities and limitations. But we do see an expanding number of states entertaining early release programs for people who are no longer considered to be a risk to the community. And so we incorporate new risk assessment instruments that take into consideration things like frailty, age, as was already discussed, infirmity, and release on various forms of supervision, including medical parole or compassionate release. And we see a lot of different combinations of solutions in that kind of bucket of ideas. I'll talk about one in just a minute. We also see external contracts with community-based third-party secure facilities that don't just approximate the community standard of care, they literally are the community standard of care. And oftentimes when those programs are voluntary, meaning that somebody is not technically in custody, and community-based, so outside the walls of a prison, those services are then reimbursable to third-party payers like Medicare and Medicaid. And that takes the financial burden off of the state in the same way that they would have to, that you would all have to pay for care that happens in custody. And then last is purpose-built correctional medical units and facilities. And states are more and more turning to retrofitting or creating new facilities that are purpose-built to meet this mission, that really appreciate the medical and behavioral health needs of the population, the unique operational response required from both custody and healthcare staff, and then building facilities that specifically meet those clinical needs, but are just as secure as any other prison is, but just very intentionally designed that way. So I mentioned a few examples, and there are several from across the country, and we can provide more if people are interested. But Massachusetts, through its Criminal Justice Reform Act of 2018, one of many sweeping reforms was to expand their medical parole program. And they allow for the early release of inmates with terminal illnesses or permanent irreversible incapacitation that renders them no longer a public safety risk. And again, there is a very careful risk assessment completed. And it does require a licensed medical evaluation, a superintendent review, and parole board approval. But in Massachusetts, the question that has come up quite frequently is release to where? And across the country, we have seen the closure of many skilled nursing facilities and others that would be qualified and capable of handling a population like this. And so this is why it's not just a policy question, it's also an infrastructure question to create that continuum of care and the capacity in the community to meet these needs as well. A good example of one of those locations, maybe the best, maybe the only one that seems to have mastered it in the research that I've done, is in Connecticut. They have a program at 60 West that is contracted with the Connecticut Department of Corrections, and they specialize in what they call difficult to place patients. And of course, some of those are folks coming out of Connecticut prisons. And they're the first facility in the country that won approval from the Centers for Medicare and Medicaid Services, CMS, for federal nursing home funding. There's a secured cognitive impairment unit, an open long-term care unit, and it treats people with degenerative medical conditions like dementia, Parkinson's, MS, Huntington's, and a terminal hospice level of care as well. Adults in custody there are carefully screened and assessed for community safety, and they're placed after an exhaustive investigation, again, into their risk for violence or criminality in the future, again, taking into consideration the unique features like frailty, age, and infirmity, which we don't normally incorporate into our classification or release processes. Interestingly, folks from Oregon DOC were invited to tour this facility, and I believe people will be going out there in a couple of weeks to check it out. And spoiler alert, it's not all that interesting as a facility because it is a community-based nursing home is what it looks like. And the folks there are infirmed and they're aging and they are reaching their end of life. And then lastly, I want to talk about specialized agency facilities. So these are inside the walls of prisons. So the best example that I'm aware of, and I've seen it, is California's correctional healthcare facility in Stockton. This is a medical and behavioral health facility with licensed medical and psychiatric beds, 1.2 million square foot medical complex that was built in 2013. And again, it was purpose-built, designed to provide intermediate and acute medical and mental health care to adults in custody in California. So again, it operates as a licensed general acute care hospital, a correctional treatment center or CTC, and it has specialized units for hospice, hospice level care, and psychiatric treatment. And when you visit it, it's remarkable. It looks and feels and operates much more like a hospital than a traditional prison, and yet it is as secure as a prison can be. It's a very interesting place to see for correctional practitioners and legislators alike. And so if these other correctional systems approaches are any indicator, applying these practices in Oregon would have an impact on health outcomes, on staff morale, certainly, and on state budgetary resources. And it certainly could also help Oregon to reduce its risk for litigation, court intervention, or a catastrophic infrastructure event in an aging facility. And with that, let me turn it back to Director Reese.
Thank you so much. On the slide, am I correct? Is the first two examples, geriatric parole and third-party provider, would both be able to pull in Medicaid and Medicare dollars? And would the California example not be able to pull in Medicaid and Medicare providers, or are all three able to get federal healthcare funds?
It would be my understanding that the geriatric parole and a third-party provider would potentially be eligible for Medicare, Medicaid funding. Certainly, any prison system is not currently under the law.
Thank you.
So as we close out our presentation, I wanted to highlight the different options, policy options, and concerns as we move forward. But one thing is really clear from this discussion: we need to replace the Oregon State Penitentiary. It is an antiquated, failing facility that doesn't meet the needs of the adults in custody, the medical needs, the mental health needs. This isn't about growing our prison footprint. It's about replacing beds that we already have in a purposeful manner, an intentional manner, to meet the needs of that population. The benefits to that are improving the outcomes for the health of the adults in custody, better working conditions for our staff. Yesterday, the superintendent at OSP told me that the temperature inside the housing units was over 90 degrees. That is typical for summer days at the Oregon State Penitentiary. And winter, it's the reverse. It's incredibly cold inside those housing units. And there will be long-term cost savings for the state when we go from a maximum security facility to a purposeful built medical facility for that population that needs it. There are other options that we want to explore. Many of them you've heard about today, and there are others out there that we're looking at. But replacing or remodeling the Oregon State Penitentiary is necessary for us to plan for and be thoughtful as we move forward. Thank you very much.
Any questions? Representative Chechi?
Yeah, the first thing's not a question. I'd be interested to hear from Dr. Timmy after this trip what it looks like to have healthcare in a prison system where they have publicly funded healthcare instead of treating human beings like a blood host to line the pockets of insurance and big pharma. That'd be interesting. But if we have a population that's 50% behind bars because of Measure 11, why is Measure 11 reform not our first question on replacing OSP? Because I can't imagine that OSP houses more people than you could revert to other locations or work on getting them back into the community or back home with their families for their own care, healthcare. At a time where we can't get services funded and we're laying off teachers and we have every bill we bring forward, the co-chairs telling us we're not going to pay for anything, why are we not talking about that first?
Can I ask a clarifying question off of that? Is half of the prison population serving?
Over 60.
What?
Half of the over 60 population is Measure 11, sorry.
Chair Krupp, Representative Chai-Chi, I'm not certain, we'll get the exact numbers of how many of our over 60 is Measure 11. 75% of our total population is there for person crimes, which are primarily Measure 11.
I'm assuming the over 60 population is a very high percentage of minimum mandatory sentences. Okay. Representative Mannix?
Just to put things in context, the original Measure 11, which is largely in effect, the mandatory minimum sentences other than murder were up to 10 years. 10 years was the highest, except for murder, which was 25 years. Later, for repeat Measure 11 offenders, people who had served their time and are released and again commit a violent crime, you could have a 25-year sentence for rape or for murder. And I'm leaving out aggravated murder because that was never a Measure 11 offense, and it had life sentences. So we need to be careful as we discuss a calculation of sentencing. Measure 11 was changed by the voters when they said for several categories of repeat Measure 11 offenders, they will have enhanced mandatory minimums. I'm told that that's about 15 or 17, 20 people a year. It's not a tremendous number. So when we're analyzing these figures, we need to keep that in mind. And I'll say one word that has not been discussed today. Separate from rehabilitation and reentry and healthcare, we have accountability. And that is one of the strong elements of the original Measure 11. Because when Measure 11 was passed, and I'll stop after this, the sentencing guideline for first-degree rape was 22 months. Measure 11 said you commit first-degree rape, it's at least 10 years in prison. And that was below the average national sentence for rape. What I'm getting at is we can have a discussion about this separately. I buy into the notion we have to deal with geriatric care, we have to deal with the institutional framework. All of these issues that are being addressed today need to be addressed. I think we get a little mixed up if we start talking about mandatory minimum sentences set by a vote of the people, because you're going to need a 2/3 vote of the House and a 2/3 vote of the Senate to change that. I think we're much better off talking about what we do about the healthcare delivery system, the infrastructure, and all of the services that are being provided, because I think you are doing a wonderful job with those. And one of the other elements, the same day Measure 11 passed, we passed Measure 17, which allows you to provide counseling and work and all of those important reentry factors, and I commend you on that. I'll stop. Thank you.
Representative Chai-Chi?
I think that the people who are providing the services, the folks who get to decide if they're going to say somebody has had good behavior, are the ones who are in a position to know if somebody can be re-released. And it feels like we've handcuffed, no pun intended, the hands of the people who are doing the work that could be saying, we don't need to hold on to these people forever. They are not a threat to the community. There are plenty of wonderful people who get to know our AICs who can say it is not doing them or the state of Oregon or the taxpayers or the voters any good to keep them locked up. And we could be saving a crap ton of money also if we're not having to care for them. Because even if they were outside, yes, they might be getting Medicaid, they might be getting OHP, but it is going to be significantly cheaper to have actual health care provided through a healthcare venue than making our corrections department become health care. That's not an efficient use of our resources.
Vice Chair Chilton?
Thank you, Chair. Not going to weigh in on this debate, although I have many thoughts, but I do want to share with the committee that, I really appreciate the presentation. One of the ideas up there was the medical release piece. One of many options, or perhaps the idea is to choose multiple options, and that's a piece I'm really interested in working on in 27. So sharing with the public, but also more so, I think, with my colleagues, if that's a piece that you'd like to engage on and try to figure out how do we find common ground on how do we get this right for Oregon, would love to get input from that sooner rather than later.
We haven't built a new prison in a stretch, right? Probably the one in Madras is the newest.
Chair Krupp, I believe 2007 was the last prison construction.
And then that growth of prisons we built a couple different ones I'm trying to remember, like in the 90s and early, the and that was sort of post-Measure 11. And then at the time, were we just not fully anticipating this sort of trend for an aging prison population? I'm just, in hindsight, were we not thinking that there was going to be this
Yeah,
increased
Chair
ratio?
Krupp, I think this is a national trend that you have an aging prison population. We're not alone in this. When I meet with our corrections leaders across the United States, this is a common theme and a challenge for many of our jurisdictions.
It's also, honestly, it's a challenge just for our healthcare system in general. I mean, if you look at the general population in Oregon as far as percentage of young people versus the percentage of people over 60 or 65. Thank you for this. I mean, what stood out to me is we have like a very complicated, in some respects, complicated criminal justice system. And Representative Mannix and Representative Chaichi, I think there was, I know that you guys were sort of debating this a little bit, but I think there were things I agreed with both of you, what you said. You know, the part of the challenge is, as a state, we have taken on a significant financial responsibility to provide attorneys for people who are charged for the crime. I think that budget's $700 and some million. And then house people or supervise people that have been committed with crime. That budget's 2.6 billion. We partnership with our local district attorney's office and the police department and court systems, but we don't necessarily have a ton of. They get to sort of impact our budget in some respects by how they sentence and how they prosecute people. And it is interesting to see different stakeholders be able to impact different government entities' budget without necessarily, input both ways. Representative Mannix, I appreciate the work that you've done in this space in this respect. And the thing I do agree with you is you talked about the votes it would take to do large-scale sentencing reform. It would have to be a bipartisan process. I sort of think we are due for a holistic look at both our sentencing grid and how we sentence significant criminal cases. And I say that with somebody who's prosecuted people who are still housed in the Department of Corrections and will be there for a long period of time. They committed incredible harm. The thing that is on my mind is I want accountability for folks. I want to be able to adhere to the values that Department of Corrections has, but I also want to help repair harm for people who've experienced that, right? Like, we spend so much more money incarcerating folks than we do for medical care, mental health care, or housing for the victims of these crimes. And I know all of us in this committee have worked on those types of issues to try to increase that funding, try to increase those supports, but it's really a fraction of what we spend on it's a fraction of what we spend providing lawyers for people charged with crimes, quite honestly, not corrections. So Representative Mannix and other members of the committee, I would welcome a bipartisan participation in is there, and I don't know the answer to this, is there some modernization to our sentencing framework?
Yeah?
Yes, please.
I do think the geriatric care issue, when we're dealing with people who have limited physical capability, allows us to also redefine what is considered secure custody. And we also have to then navigate what the federal standards may be for outside medical insurance being available, or Medicaid or Medicare for those, because if they're in a prison, it's not going to work. If they're in a type of secure custody where you reevaluate how you define it based on the person's condition, that's something we've not done before. And there's an opening there.
I appreciate that. That also that would take a significant change in our law.
Yeah.
And that would be a bipartisan effort as well. So I welcome anybody who wants to participate in that conversation. I think it's sort of timely with, and Representative Chaichi, what you talked about is budget pressures we're facing in this upcoming biennium and the subsequent biennium. And especially, you are probably the third largest general fund budget in the state, I think. It goes probably K through 12, and then OHA, and then you, is that right?
EHS is number one.
EHS, okay. It's close. Got you, all right. Members, any other questions or comments? Great. Thank you for being here, Director, and thank you, DOC team. Thank you. With that, members, that closes that informational hearing. That closes our committee hearing today.